Welcome to Ultrasound at the Front Door, the power of POCUS, and we're going to be talking about echo in COVID-19. This is us sharing our knowledge and skills and really the experience that we've had so far with COVID-19 at City Hospital, Birmingham. So how will point of care ultrasound in echo help us in COVID? Well, actually, we know that there's been case reports up to 10% in COVID-19 reporting acute myocarditis. However, this tends to happen in the more sicker patients, often in ITU. I think it's very useful if we want to differentiate other pathology, such as pulmonary edema. Remember, the pleural line will be thin and smooth. But also what we're seeing is an emergence of acute pulmonary embolism, not just in the acute phase, but also in the convalescent phase as patients are sitting at home, lying down for long periods and developing DVTs and then going on to have massive PEs. COVID-19 in itself is thrombogenic. I also think echo is really important when we're making decisions about who should be escalated for intensive care, as if patients who on the surface look very well and essentially have no past medical history, but they may have poor systolic function, which is really not ideal for patients who are going to be on ventilators. So I'm just going to talk through a few cases. I myself have not seen any cases of acute myocarditis. I have seen cases of pulmonary embolism, but I will be sharing the things that you need to think about when you're scanning patients' hearts in COVID-19. So this is a patient who is incredibly short of breath, and what we can see here is a parasternal long axis, and we can see the descending aorta, and beneath it is this black space here, which is essentially pleural fluid. Look at this LV, it's not doing anything, it's not coming in at all, not coming into my pointer at all. The septum and the posterior wall is not thickening. This is a case of a global cardiomyopathy and can happen due to consequence of myocarditis. And this is an M mode where we're slicing the heart and the LV is not coming in or out as we would expect it to. This is a short axis. Even though the LV is nice and round, it is not coming in or thickening at all. So global severe LV systolic dysfunction. 4-chamber view, again, same patient, it's not doing anything. The LV is shot, it's not moving in or out as we would expect it. Case 2. This patient was being treated for acute bilateral pneumonia. You can see the heart is big, but actually there's upper lobe diversion and bilateral congestion, and this is the scan. And again, you can see, very similar to the previous case, the LV is not doing much. The septum and the posterior wall is not thickening, it is not coming to my red lighter, and it's not doing anything. So again, the systolic function is poor. And when you measure the diastolic distance, it is dilated. And we'll pop some colour through. Patient has severe mitral regurgitation. This is a parasternal short axis, and we can see again the LV is not doing much at all. It's hardly moving. Again, severe systolic dysfunction. The 4-chamber view, the right side is normal size, but the left side is looking dilated by eye, but again the function is poor. And when we put colour on, we can see the severe mitral regurgitation, and there is also tricuspid regurgitation, which again demonstrates patient with severe global hypokinesia and severe systolic dysfunction. Case 3. So this is a patient with acute shortness of breath, and we can see, remember I mentioned the descending aorta, a key structure. Above it there's this black space which is pleural fluid. But look at this right side is dilated, and an ECG will help us, and you can see that there is right bundle branch block S1 Q3 T3, which is a sign of pulmonary embolism. This is a chest x-ray, and you can see that there's bulky pulmonary arteries as well as a big heart. But what's key is the short axis. The round structure of the LV has gone. It is now become a D shape, and this is classical of a massive PE when there's increased right-sided pressures and the right side is pressing on the left side, and this is a sign of a pulmonary embolism. Again, not a great image, but this is real patients, and we can see that the right side is the same as the left side, suggesting the right side is dilated. And the patient has severe tricuspid regurgitation, which keeps him with pulmonary hypertension as well as right heart dilatation. IVC is dilated at 2.5 centimetres, which is not a good sign. Patient goes on to have a CT scan, CTPA, which confirms, as you can see, massive clot within the main pulmonary arteries. So patient had acute pulmonary emboli with features of increased right-sided pressures and right heart strain. Next case, remember when patients are coming in shocked and unwell, don't forget about pericardial effusion. And this patient has a bubbling heart in lots of fluid. And there's a descending aorta, the really important structure, because fluid above it is pericardial fluid. We look for RV diastolic collapse, and there's a 4-chamber view and the heart is bobbing away in fluid. Remember, big effusions are safer than small effusions because they grow slowly. Small effusions, when they grow, they can cause and lead to acute tamponade. And this is a subcostal view, a very important view, because this is where we stick the needle in to relieve the pressure, and this again shows fluid around the heart. The IVC here in this case is not dilated, because if the IVC was dilated, it would tell you about impending tamponade. So really, COVID-19 and echo, it can really help you when you're dealing with patients who come in with shock. And these are the really sick patients, often in ITU or presenting in resus. Think about pulmonary embolism, a pericardial effusion and hypovolemia. It's really important when we're deciding who should be a candidate for intensive care, assess the LV function, and this can take 5 to 10 minutes, and that will aid you and the intensive care team to see if the patient is appropriate for escalation. Cases up to 10% of COVID have been reported as acute myocarditis. Look at the LV, scan the patient in all the views, and this will aid you in making decisions in escalation and treatment of the patient.